I'm Dr. Alicia Cummings, and I'm going to take you on a short journey today to learn about the sound and why it can be so challenging for children to learn to produce correctly. But before we get talking about the specifics of errors in children with speech sound disorders, let's clarify this population of children we're going to be talking about. So children with speech sound disorders have difficulty with the perception, phonological representation, and or motor production of speech segments, all of which can negatively impact their speech production accuracy and intelligibility. And it's important to understand speech sound disorders because approximately 10% of all preschool children have some difficulty with the production of speech sound segments, with the overall prevalence of speech sound disorders ranging from 2 to 24% of children, depending on the age at which the children are examined. Importantly, 80% of the children of these children are going to require intervention to remediate their speech production errors. In up to 25% of these children are going to later develop reading difficulties and or receive a literacy deficit or dyslexia diagnosis. So let's now talk a little bit about what the is. So the R can be classified as a consonant phoneme or sound. It is a sonorant and a continuant sound. In terms of the sound manner class, it is part of the approximant category, and more specifically, it's referred to as a liquid phoneme. Its official International Phonetic Alphabet, or IPA, transcription is an upside down but the right side up is often used when transcribing. And the is often characterized as a late acquired sound, but a recent study by Crow and McLeod in 2020 found that this wasn't necessarily the case. Here, this infographic displays the average age across many different studies of American English-speaking children, at which 90% of American English-speaking children produce a sound correctly. For the we can see that 90% of children are able to produce the correctly before their 6th birthday. So before most children enter 1st grade, they should be producing the sound correctly. And in order to correctly produce the we need to have multiple points of constriction in our mouth. So first, there needs to be palatal constriction, where if you think of my tongue, or you think of my hand as the tongue, and this is the back part of our tongue, we need this back part of our tongue, also referred to as the dorsum, close to the roof of our mouth. So that is our palatal constriction. And then we need to have pharyngeal constriction, where the tongue root is pulled back into the pharynx. So essentially your tongue root is the front part of your throat, and you need to pull this back into your throat. So if you think of the root of your tongue at the back of your throat, we got to pull that back, and we need to achieve this pharyngeal constriction. And finally, we need the sides of our tongue. We need the sides of our tongue to be braced against those back molars. So I often tell my kids they need to hug the sides of their teeth. So the sides of the tongue need to be touching those molars. And often we have a little bit of a dip in the middle of our tongue. It sort of looks like a butterfly, where the center of the tongue is slightly lowered as compared to the sides of the tongue. We need all 3 of those points: palatal constriction, pharyngeal constriction, and the lateral tongue bracing, in order to accurately produce an sound. And this complexity of this configuration of your tongue is often why children have difficulty correctly producing the sound. And so children can achieve that palatal constriction, with that tongue to the close to the top of our mouth, by either producing a retroflex or a bunched So the retroflex is characterized by the tip of our tongue being placed close to the top of our palate. Here we have 2 side views, ultrasound side views of a speaker. And so here in this retroflex, we can see this tongue tip right here up to close to the top of the mouth. And so that's where we're achieving that palatal constriction with the retroflex production. Here with the bunched R, what we see that dorsum of the tongue right here being brought up close to the top of the mouth. And that is where we're achieving the palatal constriction with a bunched R. And while the retroflex R can be slightly easier to teach because we just tell the kids to get their tongue up to the top of their mouth, usually the bunched R occurs in more contexts, and it's typically the one that I prefer to teach because we have it in more productions in our R throughout English speech. And I also just want to emphasize that studies looking at different speakers' productions of R's have shown that there are many different slightly variant productions of the R in terms of the tongue shape, the tongue constriction. And so there's not only one way to produce the Every speaker has to figure out the appropriate way to get the constriction of that palatal, pharyngeal, and lateral tongue bracing in order to get the R that works for them. So this makes it exceptionally difficult for kids just because there are so many different ways that this can be achieved. I also want to point out that we can see the evidence of this constriction when we do acoustic analysis of our kids' speech. And so here, right here, is a child's correct production of the word raw, like raw meat. And this is a 6-year-old who was in treatment with me for 4 months, and this is his production at the end of speech. And what we want to look at here in this figure are these bottom 3 lines here. These 3 lines represent 3 of the formants of kids' speech, and this is a spectrogram. And the bottom line is the first formant, second formant, third formant. And what I want to point out here is that that third formant and the second formant are nearly right on top of each other. And that's what characterizes a correct R production, where that second and third formant are very close to each other. And this is in contrast to the same child's production of raw before we started treatment. So here we can see your second and first formants down here, while that third formant is way up here. We have a very large space between the two. This is characterizing that we did not have appropriate constriction of the palate and of the pharynx in order to, and tongue brace in order to achieve that correct production. And so when we're looking at treatment progress, we're typically relying on our perception of children's speech. What we're hearing, was it a correct or incorrect R? But we also do make use of these acoustic cues to measure subtle changes in children's production over time. So we will measure the difference between that second and third formant over time to see how those decrease. That is providing additional evidence for change occurring due to treatment.